Shock, systemic inflammatory response syndrome or SIRS, sepsis, and multiple organ dysfunction syndrome or MODS are all serious and interrelated problems. Today we're going to start by talking about shock. Shock is a syndrome characterized by decreased tissue perfusion. This results in an imbalance between the supply of and the demand for oxygen and nutrients. The exchange of oxygen and nutrients at the cellular level is essential for life. When cells are hypoperfused, the demand for oxygen and nutrients exceeds the supply at the microcellular level. Ischemia can occur, leading to cell injury and death. Thus, shock of any cause is life-threatening. This chapter gives an overview of the different types of shock, of SIRS, sepsis, and MODS, and the related management of each. The four main categories of shock management of each. The four main categories of shock are cardiogenic, hypovolemic, distributive, and obstructive. There's a table 66.1 in your textbook that refers to this. Although the cause, the initial presentation, and management vary for each type, perfusions are similar. So let's begin with cardiogenic shock. Cardiogenic shock occurs when either systolic or diastolic dysfunction of the heart's pumping action results in reduced cardiac output, stroke volume, and blood pressure. These changes compromise myocardial perfusion, further depressing myocardial function and decreasing cardiac output and perfusion. Causes in cardiogenic shock are shown in Table 66.1. Mortality rates for patients with cardiogenic shock are around 50%. It is the leading cause of death from acute myocardial infarction or an MI. The heart's inability to pump the blood forward is called systolic dysfunction. This inability results in low cardiac output, less than 4 liters per minute, and cardiac index, less than 2.5 liters per minute. Rarely affects the left ventricle since systolic pressure is greater on the left side of the heart. The most common cause of systolic dysfunction is acute MI. When systolic dysfunction affects the right side of the heart, blood flow from the pulmonary circulation is reduced. Decreased filling of the heart results in decreased stroke volume, shown once again in Table 66.1. This is Figure 66.2 from your textbook, and it demonstrates the pathophysiology of cardiogenic shock. Whether the first event is a myocardial dysfunction, a structural problem such as a valvular disorder or a ventral septal rupture, or dysrhythmias, the patient experiences impaired tissue perfusion and cellular metabolism because of the cardiogenic shock. The early presentation of a patient with cardiogenic shock is similar to that of a patient with acute decompensated heart failure. The patient may have tachycardia and hypotension. The pulse pressure may be narrowed, due to the heart's inability to pump blood forward during systole and increased volume during diastole. An increase in systemic vascular resistance, or SVR, increases the workload of the heart. This increases myocardial O2 consumption. On assessment, the patient is tachypnic and has crackles on auscultation of breath sounds because of pulmonary congestion. The hemodynamic profile shows an increase in the pulmonary artery wedge pressure, or the PAWP, stroke volume variation, or the SVV, and pulmonary vascular resistance. Signs of peripheral hypotension such as cyanosis, pallor, diaphoresis, weak peripheral pulses, cool and clammy skin, and delayed capillary refill, all water retention, and decreased urinary output. Anxiety, confusion, and agitation may develop with impaired cerebral perfusion. Tables 66.2 and 66.3 describe the laboratory findings and clinical presentations of patients with cardiogenic shock. Moving on to hypovolemic volume in the intravascular space to support adequate perfusion. The volume loss may be either an absolute or a relative volume loss. Absolute hypovolemia results when fluid is lost through hemorrhage, gastrointestinal or GI loss, such as vomiting and diarrhea, fistula, or diuresis. In relative hypovolemia, fluid volume moves from the vascular space into the extravascular space, such as the intracavitary space. We call this type of fluid shift third spacing. One example of relative fluid volume loss is fluid leaking from the vascular space into the relative fluid volume loss is fluid leaking from the vascular space into the interstitial space from increased capillary permeability, such as what we see with burns. This is figure 66.3, and it shows the pathophysiology of hypovolemic shock. You can compare it to the pathophysiology of hypovolemic shock. You can compare it to the pathophysiology of cardiogenic shock. Whether the loss of intravascular volume is absolute or relative, the physiologic consequences are similar. The reduced intravascular volume results in decreased venous return to the heart, decreased preload to the heart, decreased preload, decreased stroke volume, and decreased cardiac output. A cascade of events results in decreased tissue perfusion and impaired cellular metabolism, the hallmarks of shock. The patient's response to acute volume loss depend on several factors. General state of health. Clinical presentation of hypovolemic shock is consistent, and it's shown in Table 66.3. An overall assessment of physiologic reserves may indicate the patient's ability to compensate. A patient may compensate for a loss up to 15% of the total blood volume, which is around 700%, results in a sympathetic nervous system mediated response. This response results in increased heart rate, increased cardiac output, and increased respiratory rate and depth. The decreased circulating blood volume causes decreases in stroke volume, central venous pressure or the CVP, and the pulmonary artery wedge. The patient may appear anxious. Urine output begins to decrease. If hypovolemia is corrected by crystalloid fluid replacement at this time, tissue dysfunction is generally reversible. If the volume loss is greater than 30%, compensatory mechanisms may fail and immediate replacement with blood products should be started. Loss of autoregulation in the microcirculation and irreversible tissue destruction occur with loss of more than 40% of the total blood volume. Common laboratory studies and assessments that are done include serial measurements of hemoglobin and electrolytes, lactate, blood gases, mixed central venous O2 saturations, and hourly urinary outputs. There's a table 66.2 in your book that talks about this. At this point, your textbook talks about neurogenic shock. I'm going to save that information for when we do injuries in Unit 4. So now let's talk about anaphylactic shock, which is a hypersensitive reaction to a sensitizing substance. Most commonly, these substances could be drugs or chemicals, food, or any kind of venomous animal or insect or plant, and most recently we've talked about hypersensitive reaction to vaccines. The reaction causes massive vasodilatation, release of vasoactive mediators, and an increase in capillary permeability. As capillary permeability increases, fluid leaks from the vascular space into the interstitial space. The patient has a sudden onset of symptoms, including dizziness, chest pain, incontinence, swelling of the lips and tongue, wheezing and stridor. Skin changes include flushing, pruritus, urticaria, and angioedema. The patient may be anxious and confused and have a sense of impending doom. IV administration of the allergen is the route most likely to cause anaphylaxis. However, oral, topical, and inhalation routes can describe the laboratory findings and the clinical presentation of a patient with anaphylactic shock. Quick and decisive action is critical to prevent an allergic reaction from progressing into anaphylactic shock. In understanding septic shock, we first need to be aware that sepsis is a life-threatening syndrome in response along with new organ dysfunction related to that infection. In as many as 30% of patients with sepsis, the causative organism isn't identified. Sepsis and septic shock have a high incidence worldwide with a high mortality rate of 25% or higher. Septic shock is a subsidy risk due to profound circulatory, cellular, and metabolic abnormalities. Septic shock is characterized by persistent hypotension despite adequate fluid resuscitation and inadequate tissue perfusion that results in tissue hypoxia. The main organisms that cause sepsis are gram-negative and gram-positive. The main organisms that cause sepsis are gram-negative and gram-positive bacteria. Parasites, fungi, and viruses can also cause sepsis and septic shock. Figure 66.5 presents the pathophysiology of septic shock. Patients may be euvolemic, but because of acute vasodilation and shifting shock. Patients may be euvolemic, but because of acute vasodilation and shifting of fluids out of the intravascular space, relative hypovolemia and hypotension occur. Blood flow in the microcirculation is decreased, causing poor O2 delivery and tissue hypoxia. We think there are immunofactors that may play a role in sepsis-induced myocardial dysfunction. The ejection fraction is decreased in the first few days after the initial insult. Because of a decreased ejection fraction, the ventricles dilate to maintain the stroke volume. The ejection fraction typically improves and ventricular dilation resolves over increased development of hypotension and MODS, which is multiple organ dysfunction syndrome. Coronary artery perfusion and myocardial oxygen metabolism are not primarily altered in septic shock. Respiratory failure is common. The patient initially hyperventilates as a compensatory mechanism causing respiratory alkalosis. Once the patient can no longer compensate, respiratory acidosis develops. Respiratory failure develops in 85% of patients with sepsis, and 40% develop acute respiratory distress syndrome or ARDS. These patients may need to be intubated and mechanically ventilated. Other signs of patients may need to be intubated and mechanically ventilated. Other signs of septic shock include changes in neurological status, decreased urinary output, increased GI dysfunction such as GI bleeding and paralytic ileus. There's a table 66.3 in your textbook that gives the clinical presentation of a patient with septic. 66.3 in your textbook that gives the clinical presentation of a patient with septic shock. Lastly, we're going to talk about obstructive shock, which occurs when there's a physical obstruction to blood flow that causes decreased cardiac output. It can be things that actually happen in the chest, such as cardiac tamponade, a tension pneumothorax, or superior vena cava embolus, and right ventricular thrombus can also obstruct the blood flow. Other causes include abdominal compartment syndrome, in which increased abdominal pressure compresses the inferior vena cava. This decreases venous return to the heart. This leads to decreased blood flow to the lungs and decreased blood return to the left atrium, cardiac output, increased afterload, and a variable left ventricular filling pressure depending on the obstruction. Other signs include jugular vein distension and pulse paradoxis. Rapid assessment and treatment are important to prevent further hemodynamic compromise and possible cardiac arrest. In addition to understanding and possible cardiac arrest. In addition to understanding the underlying pathogenesis of the type of shock the patient has, management is guided by knowing when the patient is on the shock continuum. We categorize shock into 4 overlapping stages. 1, the initial stage, 2, the compensatory stage, and 4, the refractory stage. The continuum begins with the initial stage of shock that occurs at a cellular level. This stage is usually not clinically apparent. Metabolic changes at the cellular level from anaerobic to aerobic cause the lactic acid buildup. Lactic acid is a waste product that requires oxygen, which is unavailable because of decreased tissue perfusion. In the compensatory stage, the body activates neural, hormonal, and biochemical compensatory mechanisms to try to overcome the increased consequences of anaerobic metabolism and to maintain homeostasis. The body's response to the imbalance in oxygen supply and demand. A classic sign of shock is a drop in blood pressure. This occurs because of a decrease in cardiac output and a narrowing of the pulse pressure. The bioreceptors in the carotid and aortic bodies immediately respond by activating the central nervous system. The central nervous system stimulates vasoconstriction and the release of the potent vasoconstrictors epinephrine and norepinephrine. Blood flow to the heart and brain is maintained. Blood flow to the non-vital organs such as kidneys, GI tract, skin and lungs is diverted or shunted. The myocardium responds to the central nervous system stimulation and the increase in O2 demand by increasing the heart rate and contractility. Increased contractility increases myocardial O2 consumption. The coronary arteries dilate to meet the increased O2 demands of the myocardium. An important clinical effect on the patient in shock. Decreased blood flow to the lungs increases the patient's physiologic dead space. Physiologic dead space is the anatomic dead space, which is the amount of air that will not reach gas exchange units and any inspired air that cannot take part in gas exchange. The clinical result of an ventilation perfusion mismatch. Some areas of the lung that are being ventilated will not perfuse because of the decreased blood flow to the lungs. Arterial O2 levels will decrease, and the patient will have a compensatory increase in the rate and depth of respiration. The shunting of blood from other organ systems results in clinically. The decrease in blood flow to the GI tract results in impaired motility and slowing of peristalsis. This increases the risk of a paralytic ileus. Decreased blood flow to the skin results in the patient feeling cool and clammy. The exception is the patient in early septic shock who may feel warm and flushed. Because of a hyperdynamic state. Decreased blood flow to the kidneys activates the renin-angiotensin system. Renin stimulates angiotensinogen to make angiotensin 1. Which is then converted to angiotensin 2, vasoconstrictor that causes both arterial and venous vasoconstriction. The net result is an increase in venous return to the heart and an increase in blood pressure. Angiotensin 2 stimulates the adrenal cortex to release aldosterone. This results in sodium and water reabsorption and potassium excretion by the kidneys. The increase in sodium reabsorption raises the serum osmolarity and stimulates the release of antidiuretic hormone, or ADH, from the posterior pituitary gland. ADH increases water reabsorption by the kidneys, further increasing blood volume. The increase in total circulating volume further increasing blood volume. The increase in total circulating volume results in an increase in cardiac output and blood pressure. A multi-system response to decreasing tissue perfusion starts during the compensatory stage of shock. At this stage, the body can compensate for the changes in tissue perfusion. If the cause of the shock is correct, the body can compensate for the changes in tissue perfusion. If the cause of the shock is corrected, the patient will recover with little or no residual effects. If the cause of the shock is not corrected and the body is unable to compensate, the patient enters the progressive stage of shock. The progressive stage of shock begins as compensatory mechanism. Changes in the patient's mental status are important findings in this stage. The patient must be moved to the intensive care unit, if not already there, for advanced monitoring and treatment. The cardiovascular system is profoundly affected in the progressive stage of shock. Cardiac output begins to fall, resulting in decreased blood pressure and coronary artery. Altered capillary permeability allows fluid and protein to leak out of the vascular space into the surrounding interstitial space. In addition to the decrease in circulating volume, there's an increase in systemic interstitial edema. The patient may have anasarca, which is profuse profound edema. Fluid leakage from the vascular space affects the solid organs like the liver, the spleen, the GI tract, and the lungs, and the peripheral tissue by further decreasing perfusion. Sustained hypoperfusion results in weak peripheral pulses, and ischemia to the distal extremities eventually occurs. Myocardial dysfunction from decreased perfusion results in dysrhythmias, myocardial ischemia, and possible MI. The result is complete deterioration of the cardiovascular system. The pulmonary system is often the first system to display signs of critical dysfunction. During the compensatory response to the decreased blood flow and the sympathetic nervous system stimulation, the pulmonary arterioles constrict, resulting in increased pulmonary artery pressure. As the pressure within the pulmonary vascularity increases, blood flow to the pulmonary capillaries decrease and ventilation perfusion mismatch worsens. Another key response in the lungs is the movement of fluid from the pulmonary vasculature to the interstitial space. As capillary permeability increases, the movement from the fluid to the interstitial spaces results in interstitial edema, bronchoconstriction, and a decrease in functional residual capacity. With further increases in capillary permeability, fluid moves into the alveoli, causing alveolar edema and a decrease in surfactant production. The combined effects of pulmonary vasoconstriction and bronchoconstriction are impaired gas exchange, decreased clinically the patient has tachypnea, crackles, and overall increased work of breathing. The GI system is affected by prolonged decrease in tissue perfusion. As the blood supply to the GI tract is decreased, the normally protective mucosal barrier becomes ischemic. This ischemia increases the risk of bacterial migration from the GI tract to the blood and lungs. The decreased perfusion in the GI tract leads to decreased ability to absorb nutrients. The effect of prolonged hypoperfusion on the kidneys is renal tubular ischemia. The resulting acute tubular necrosis may lead to acute kidney injury, or AKI. This can be worsened by nephrotoxic drugs, certain antibiotics, anesthetics, and diuretics. The patient has decreased urinary output and increased blood urea nitrogen, or BUN, and serum creatinine. Metabolic acidosis occurs from the kidney's inability to excrete acids such as lactic acid and reabsorb bicarbonate. The sustained hypoperfusion in the progressive stage of shock greatly affects other organs. The loss of the functional ability of the liver leads to failure of the liver to metabolize drugs and waste products such as lactate and ammonia. Jaundice results from an accumulation of bilirubin. As the liver cells die, liver enzymes increase. The liver loses its ability to function as an immune organ. Dysfunction of the hematological system adds to the complexity of the clinical picture. The patient is at risk for disseminating intravascular coagulopathy, or DIC. The consumption of the platelets and clotting factors with secondary fibrinolysis results in clinically significant bleeding from many GI tract, lungs, and puncture sites. Altered laboratory values in DIC are shown in Table 66.3. In this stage, aggressive interventions are needed to prevent the development of MODS. In the last stage of shock, the refractory stage, decreased perfusion from the peripheral vasoconstriction and decreased cardiac accumulation of lactic acid contributes to the increased capillary permeability and dilation. Increased capillary permeability allows fluids and plasma proteins to leave the vascular space and move to the interstitial space. Blood pools in the capillary beds due to constricted venules and dilated arterioles. The loss of intravascular volume increases coronary blood flow. Decreased coronary blood flow leads to worsened myocardial depression and further decline in cardiac output. Cerebral blood flow cannot be maintained and cerebral ischemia results. The patient in this stage of shock has profound hypotension and hypoxia. The failure of the liver, lungs, and kidneys results in an accumulation of ammonia and CO2. The failure of one organ system affects several other organ systems. Recovery is unlikely at this stage. The organs are in failure and the body's compensatory mechanisms are overwhelmed. There is no single diagnostic study to determine whether a patient is in shock. The diagnosis starts with a history and a physical examination. Obtaining a thorough medical and surgical history and a history of recent events gives valuable data. Decreased tissue perfusion in shock leads to increased lactate with a base deficit. That's the amount needed to bring the pH back to normal. These laboratory changes reflect an increase in anaerobic metabolism. Table 66.2 in your book outlines the laboratory findings seen in shock. Other diagnostic studies include a 12-lead electrocardiogram, continuous ECG monitoring, a chest X-ray, and invasive and non-invasive hemodynamic monitoring. Critical factors in the successful management of a patient in shock relate to the early recognition and treatment of the shock state. Prompt intervention in the early stages of shock may prevent the decline to progressive or irreversible stage. Successful management is at risk for development of shock. 2. Integrate the patient's history, physical examination, and clinical findings to the establishment of a diagnosis. 3. Interventions to control or eliminate the cause of decreased perfusion. 4. Protecting target and distal organs from dysfunction. And 5. Providing multi-system supportive care. Table 66.6 provides an overview of the initial assessment findings and interventions for the emergency care of patients in shock. General management strategies begin with ensuring that the patient is responsive and has a patent airway. Once the airway is established, either naturally or with an endotracheal tube, O2 delivery must be naturally or with an endotracheal tube. O2 delivery must be optimized. Supplemental O2 and mechanical ventilation may be needed to maintain an arterial O2 saturation of 90% or more. That's a PaO2 greater than 60 millimeters of hemoglobin to avoid hypoxemia. The mean arterial pressure, or the MAP, and drug therapy. O2 delivery depends on CO2, available hemoglobin, and arterial O2 saturation, or your SaO2. Methods to optimize O2 delivery are directed at increasing supply and decreasing demand. Supply is increased by 1. Optimizing the CO2 with fluid replacement and or drug therapy. 2. Increasing the hemoglobin through transfusion of whole or packed red blood cells, RBCs. And or 3. Increasing the arterial O2 saturation with supplemental O2 and mechanical ventilation. Plan care to avoid disrupting the balance of O2 supply and demand. Space activities that increase O2 consumption, such as endotracheal suctioning and position changes appropriately for O2 conservation. Intermittent or continuous monitoring of the SCVO2 by central venous catheter or mixed venous O2 saturation, SVO2, may be helpful. Both venous O2 saturation, SVO2, may be helpful. Both reflect the dynamic balance between oxygen supply and demand. Assess these values along with related hemodynamic measures such as arterial pressure-based cardiac output, O2 consumption, and hemoglobin to evaluate the patient's response to treatment and activity. Shock is volume expansion with administration of appropriate fluids. There's a table in your book, 66.7, that talks about the kind of fluids we use for volume expansion. Fluid resuscitation should start using 1 or 2 large bore, that's 14 or 16 gauge, IV catheters. An interosseous or an IO ideal choice of fluid is controversial. Currently, normal saline is most often used for the initial resuscitation of shock. Large volume resuscitation with normal saline can lead to hypercholoremic metabolic acidosis. Lactated Ringer solution can cause serum lactate levels to increase because the failing liver cannot convert lactate to bicarb. Transfusions of red blood cells may be given to treat hypovolemic shock due to bleeding. Colloids, that's 4% to 5% solutions, have not been shown to improve patient outcomes. Fluid responsiveness is determined by clinical assessment. Fluid responsiveness is determined by clinical assessment. This includes vital signs, cerebral and abdominal perfusion pressures, capillary refill, skin temperature, and urinary output. Hemodynamic parameters such as SVV or CO2 also may be used. Monitor trends in blood pressure with an automatic blood pressure cuff or an arterial catheter to assess patient response. Use an indwelling catheter to monitor urine output during resuscitation. The goal of fluid resuscitation is to restore tissue perfusion. Although blood pressure helps to determine whether the patient's cardiac, such as with urine output or neurological function or peripheral pulses, provides more relevant data. Drugs used to improve perfusion in shock are generally given intravenously via infusion pumps and central venous lines. Drugs that mimic the action of the sympathetic nervous system are termed sympathomimetic. The effects of these drugs are mediated through their binding of A. Adrenergic or B. Adrenergic receptors. These drugs have the potential to cause severe peripheral vasoconstriction and increased systemic vascular resistance. This further risks tissue perfusion. The increased systemic vascular resistance increases the workload of the heart. This can harm a patient in cardiogenic shock by causing further myocardial damage. Protein calorie malnutrition is common because of hypermetabolism. Nutrition is vital to reduce mortality. Enteral nutrition should be started within the first 24 hours. However, full calorie illness. Start the patient on a trophic feeding. This is a small amount of enteral feeds. Early enteral nutrition enhances the perfusion of the GI tract and helps maintain the integrity of the gut mucosa. Advanced feedings as tolerated and prescribed. Parenteral nutrition is used only if enteral nutrition is contraindicated. The overall goal is to restore heart function and the balance between O2 supply and demand in the myocardium. Cardiac catheterization is done as soon as possible after the initial insult. Specific measures to restore blood flow include angioplasty with stenting, emergency revascularization, and valve replacement. Until these interventions are done, we must support the cardiac output to achieve optimal perfusion. Hemodynamic management of a patient in cardiogenic shock aims to reduce the workload of the heart through drug therapy and other mechanical interventions. Drug choice is based on the clinical goal and a thorough understanding of each drug's mechanism of action. Drugs can be used to decrease the workload of the heart mechanism of action. Drugs can be used to decrease the workload of the heart by dilating the coronary arteries, as with nitrates. They can reduce preload, as with diuretics, or afterload, as seen with vasodilators. Beta-adrenergic blockers can affect heart rate and contractility. The patient blockers can affect heart rate and contractility. The patient may benefit from a circulatory assist device, such as an intra-aortic balloon pump or a ventricular assist device. The goals of this intervention are to decrease the systemic vascular resistance and left ventricular workload so the heart can heal. A VAD or a ventricular assist device may also be used as a temporary measure for a patient in cardiogenic shock who is awaiting heart transplant. Heart transplant is an option for a small select group of patients with cardiogenic shock. The underlying principles of managing patients with hypovolemic shock focus on stopping the loss of blood and restoring estimated blood loss. Table 66.7 describes types of fluid used for fluid resuscitation, the mechanisms of action, and the specific nursing implication for each type of fluid used. Patients in septic shock need large amounts of fluid replacement. The overall goal of fluid resuscitation is to restore the intravascular volume fusion. The initial volume resuscitation is achieved by giving 30 mL per kilo of an isotonic crystalloid solution. Albumin 4% to 5% may be added when the patient needs substantial volumes. A fluid challenge technique with a minimum of 30 mL per kilo of crystalloid may be used and repeated until hemodynamic improvement, which is shown with an increase in mean arterial pressure and or CVP or a change in the systemic vascular volume is seen. Table 66.9 shows predetermined endpoints of fluid resuscitation along with methods to reassess volume status. One of these methods is a passive leg raise or a PLR challenge along with hemodynamic measures to monitor response. A PLR challenge provides a transient increase in fluid volume of 150 to 500 mL by placing the patient supine and raising the legs 45 degrees. Response is monitored within 1 to 2 minutes by measuring cardiac output, cardiac index, stroke volume, systemic vascular volume, or other parameters for improvement. If the response is positive, the patient is fluid responsive and should receive more fluids. To optimize and evaluate large volume fluid resuscitation, hemodynamic monitoring with various non-invasive and invasive monitors is needed. If the patient is hypotensive, after initial volume resuscitation be added. The first drug of choice is norepinephrine. Vasodilation and low cardiac output or vasodilation alone can cause low blood pressure despite adequate fluid resuscitation. Vasopressin may be added for those who are refractory to initial vasopressor therapy. Exogenous vasodepleted in septic shock.
Vasopressor drugs may increase blood pressure but decrease stroke volume. An ionotropic agent such as dobutamine may be added to offset the decrease in stroke volume and increase tissue perfusion. IV corticosteroids may be considered for patients in septic shock who cannot maintain an adequate blood pressure fluid resuscitation. To try to meet the increased tissue demands coupled with a low systemic vascular resistance, the patient may initially have a normal or high cardiac output. If the patient is unable to achieve and maintain an adequate cardiac output and has unmet tissue O2 demands, cardiac output may have to be increased using drug therapy. O2 demands, cardiac output may have to be increased using drug therapy such as dopamine. SCVO2 and SVO2 monitoring is used to assess the balance between O2 delivery and consumption and the adequacy of the cardiac output. If balance is maintained, the tissue demands will be met. Broad spectrum Broad spectrum antibiotics are important in an early part of therapy. They should be started within the first hours of sepsis or septic shock. Obtain cultures such as blood, wound, urine, stool, or sputum before antibiotics are started. However, this should not delay the start of antibiotics within the first hour. Specific antibiotics may be ordered once the organisms have been identified. Glucose levels should be maintained below 180 milligrams per deciliter for patients in shock. Monitor glucose levels in all patients in septic shock according to proton pump inhibitors, such as pantoprazole and VTE prophylaxis with heparin or enoxaparin are recommended. To understand the complexity of the patient's clinical status, integrate all assessment data. It is essential to obtain a brief history from the patient or the caregiver, including a description of the events leading to the shock state, such as medications and allergies. In addition, obtain details about the care the patient received before hospitalization. The actual assessment focuses on ABCs such as airway, breathing, and circulation, and then we're going to do a focused assessment of tissue perfusion such as vital signs, pulses, level of consciousness, capillary skin look like, what's the temperature, color, and moisture, and then again what's the urinary output. Nursing diagnoses are impaired peripheral tissue perfusion, impaired cardiac output, and anxiety. Care goals will be to demonstrate evidence of adequate tissue perfusion, restore normal or baseline blood pressure, recover organ function, and avoid complications. You have a vital role in the prevention of shock, beginning with the identification of patients at risk. In general, patients who are older, who are immunocompromised, or have chronic illnesses are at an increased risk. Any person who's had surgery or hemorrhage, spinal cord injury, sepsis, and other problems. Planning is essential to help prevent shock after you identify at-risk persons. For example, a person with an acute anterior wall MI is at a high risk for cardiogenic shock. The main goal of this patient is to limit the infarct size. This is done by restoring coronary blood flow, intervention, thrombolytic therapy, or surgical revascularization. Rest, analgesics, and sedation can reduce the myocardial demand for oxygen. Modify the ICU environment to provide care at intervals that will not increase the patient's O2 demand. For example, if the patient becomes tired after bathing, perform this care at a time that doesn't interfere with tests or other activities that may increase O2 demand. A person with certain severe allergies such as drugs, shellfish, insect bites, and latex is at increased risk for anaphylactic shock. This risk can be decreased if the patient is carefully assessed for allergies. Your role in shock involves 1. Monitoring the patient's ongoing physical and emotional status. 2. Identifying trends to detect changes in the patient's condition. 3. Planning and implementing nursing interventions and therapy. 4. Evaluate the patient's response. 5. Provide emotional support for the patient and the caregiver. And 6. Collaborate with other members of the interprofessional team to coordinate care. Careful monitoring of fluid balance can help prevent hypovolemic shock. Ongoing monitoring of intake and output and daily weights is important. Identifying trends in the patient's condition is more meaningful than those who are immunocompromised or at high risk for opportunistic infections. Strategies to decrease the risk for healthcare-associated infections include decreasing the number of invasive catheters, such as central lines or bladder catheters, using aseptic technique during invasive procedures, and paying strict attention to hand washing.
Change equipment per agency policy. Change equipment per agency policy. Thoroughly sanitize or discard, if disposable, equipment between patient uses. Evidence-based guidelines are available to reduce the risk of healthcare-associated infections, such as ventilator-associated pneumonia, central line infections, catheter-associated urinary tract pneumonia, central line infections, catheter-associated urinary tract infections. These guidelines, called care bundles, outline key interventions aimed at reducing infections. As we implement care for the shock state, we want to consider interventions for each body system. Assess the patient's neurological status for each body system. Assess the patient's neurological status, including orientation and level of consciousness, using a valid tool at least every 1 to 2 hours. The patient's neurological status is the best indicator of cerebral blood flow. Be aware of the clinical manifestations of neurological involvement, such as changes in behavior, rest confusion, or paresthesias. Note any subtle change in the patient's mental status, such as mild agitation, and report them to the healthcare provider. Orient the patient to person, place, and time and events on a regular basis. Orientation to the ICU environment is especially important. Reduce the noise and light levels to control sensory activity and rest as much as possible. Sensory overload and disruption of the patient's diurnal cycle may contribute to delirium. Most of the therapy for shock is based on information about the patient's cardiovascular system. If the patient is unstable, continuously assess heart rate and rhythm, blood pressure, central venous pressure, and PL resistance, stroke volume, and stroke volume variation if available. Monitoring trends in hemodynamic parameters provides more important information than single values. Integration of hemodynamic data with physical assessment data is essential in planning strategies to manage the patient's shocks. In another lecture, we'll talk about the specifics of the patient's shocks. In another lecture, we'll talk about the specifics of hemodynamic monitoring. Continuously monitor the patient's ECG to detect dysrhythmias that might result from the cardiovascular and metabolic abnormalities associated with shock. Assess heart sounds for S3, S4 sounds or new murmurs. An S3 sound usually indicates heart failure. Monitor the patient's skin, both in the upper and lower extremities, for signs of adequate perfusion. Changes in temperature, pallor, flushing, cyanosis, diuresis, or piloerection may indicate hypoperfusion. Give the prescribed therapy to correct cardiovascular drug administration as often as every 5 to 10 minutes. Make appropriate adjustments, that's your drug titration, as needed. Once tissue perfusion is restored and the patient is stabilized, you can decrease the frequency of monitoring and slowly wean the patient off drugs to support blood pressure and tissue perfusion. Frequently assess blood pressure and tissue perfusion. Frequently assess the respiratory status for the patient in shock to ensure adequate oxygenation, detect complications early, and provide data about the patient's acid-base status. At first, monitor the rate, depth, and rhythm of respirations as often as every 15 to 30 minutes. Rhythm of respirations as often as every 15 to 30 minutes. Increased rate and depth provide information about the patient's attempt to correct metabolic acidosis. Assess breath sounds every 1 to 2 hours as needed for any changes that might indicate fluid overload or an accumulation of secretions. Use pulse oximetry overload or an accumulation of secretions. Use pulse oximetry to continuously monitor O2 saturation. Pulse oximetry using the patient's finger may not be adequate in a shock state because of poor peripheral circulation. Instead, attach the probe to the ear, nose, or forehead according to the manufacturer's guidelines. Your responsibility: a PaO2 below 60 milligrams of hemoglobin in the absence of chronic lung disease indicates hypoxia and the need for higher O2 concentrations or for different modes of O2 administration. Low PaCO2 with a low pH and a low bicarbonate level may mean the patient is rising. PaCO2 with persistently low pH and PaO2 indicates the needs for advanced pulmonary management. Many patients in shock are intubated and on mechanical ventilation. Maintaining a patent airway and monitoring for ventilator-related complications are crucial. In considering the renal system, At first, we want to measure urinary output. In considering the renal system, at first we want to measure urinary output every 1 to 2 hours to assess for the adequacy of renal perfusion. Inserting an indwelling urinary catheter helps measure during resuscitation. Urine output below 0.5 mils per kilo per hour may indicate inadequate perfusion of the kidneys. Use per hour may indicate inadequate perfusion of the kidneys. Use trends in serum creatinine values to assess renal function. Serum creatinine is a better indicator of renal function than BUN levels, since BUN is affected by the patient's catabolic state. We also want to monitor the patient's body temperature. We want to take their temperature about every 4 hours if normal. In the presence of a high or subnormal temperature, obtain hourly core temperatures, which can be done via a urinary, esophageal, or a PA catheter. Use light covers and control the room temperature to keep the patient comfortable. If the patient's temperature rises above 101.5 and the patient becomes uncomfortable or shows cardiovascular compromise, treat the fever with antipyretic drugs such as ibuprofen or acetaminophen and remove some of the patient's covers. Measure drainage and check for occult blood. Check all stools for occult blood. As we consider our patient's skin, we want to remember that hygiene is especially important for the patient in shock because impaired tissue perfusion predisposes the patient to skin breakdown and infection. Perform bathing and other nursing measures carefully because the patient in shock has problems. Determine priorities of care to limit the demands of increased oxygen. Monitor trends in O2 consumption, such as our SpO2 or ScVO2 or SvO2, during all nursing interventions to assess the patient's tolerance of activity. The increased O2 demand that occurs during bathing and repositioning of patients with limited O2 reserves makes the prevention of pressure injuries challenging. Turn the patient at least every 1 to 2 hours. Maintain good body alignment. Use a pressure relieving or pressure reducing mattress or a specialty bed as needed. Perform passive range and help prevent breakdown. Oral care is essential because mucal membranes may become dry and fragile in the volume-depleted patient. The intubated patient usually has difficulty swallowing, resulting in pooled secretions in the mouth. Apply a water-soluble lubricant to the lips to prevent drying and cracking. Brush the patient's teeth or gums with a soft toothbrush every 12 hours. Swab the lips and oral mucosa with a moisturizing solution every 2 to 4 hours. Do not underestimate the effects of fear and anxiety when the patient and caregiver are faced with critical, life-threatening situations. Fear, anxiety, and pain may worsen respiratory distress and increase the release of catecholamines. When implementing care, monitor the patient's mental status and level of pain using valid assessment tools. Give drugs to decrease anxiety and pain as needed. Continuous infusions of benzodiazepines such as lorazepam or an opioid or sedative such as morphine or propofol are extremely helpful in decreasing anxiety and pain. Do not overlook the patient's spiritual needs. Patients may want a visit from a chaplain, priest, rabbi, or minister. One way to caregiver to express a wish for spiritual counseling. Caregivers need to be informed of the patient's condition. Give the patient and the caregiver simple explanations of all procedures before you carry them out and information about the plan of care. If they ask questions about the progress and prognosis, give simple and honest answers. Support the patient's caregivers when making tough decisions, such as withdrawal of life support. The interprofessional care team must promote realistic expectations and outcomes. Remember, compassion is as essential as scientific and technical expertise in the total care of the patient and the caregiver. Ensure that the caregiver can spend time with the patient, provided the patient perceives this time as comforting. Explain in simple terms the purpose of any tubes and equipment attached to or surrounding the patient. Tell them what they may or may not touch. If possible, place the patient's hands and arms outside the sheets to encourage therapeutic touch. Encourage the caregivers to perform simple comfort measures if desired. Provide privacy as much as possible while assuring the patient and the caregiver that help is readily available should it be needed. Always position the call light in the reach of the patient or the caregiver. Always position the call light in the reach of the patient or the caregiver. Rehabilitation of the patient who had a critical illness requires first, correction of the precipitating cause, second, prevention or early treatment of complications, and third, teaching focused on disease management or prevention of recurrence based on the initial cause of the shock. Continue to monitor the patient for complications throughout the recovery period. These may include decreased range of motion, muscle weakness, decreased physical endurance, acute kidney injury, and fibrotic lung disease. Patients include admission to transitional care units, rehabilitation centers, or home health care agencies. Start planning for a safe transition from hospital to home as soon as the patient is admitted to the hospital. Lastly, in evaluation, we want to be sure we have adequate tissue perfusion with restoration